Good evening, friends. Welcome to this Tuesday evening critical care CME and webinars. So we tried to bring some topics of interest for all the critical care consultant practitioners from different spectrum of specialties. And in the recent past, in the last maybe half a decade, uh, just in and around COVID and post-COVID, as a department, as a critical care specialist, we have seen a new super specialty in the Department of Critical Care Medicine. That happened to be the transplant critical care, and more so for the last 2, 3 decades, we have been seeing cases with renal transplant and later hepatic transplant. But the more challenging one, which came the later part, is the lung transplant. And Yashoda been on the front line post-COVID and been doing a good number of lung transplant. And we witnessed a lot of stories, a journey from different clinicians who evolved from a regular pulmonology postgraduate to an interventional pulmonologist to a transplant pulmonologist. In the similar way, we also saw the evolution of our critical care specialists from regular critical care to a transplant and ECMO physician. So we all thought, why not we discuss this journey of the transplant critical care from both these team members. I'm happy to actually share the webinar with both young, dynamic, and seasoned clinicians, speakers, and most dynamic personalities in their field, and both of them are making a mark in their field. So I introduced Dr. Chetan. Dr. Chetan Rao Vaddepally was a interventional pulmonologist, and now he has been more recognized across as a transplant pulmonologist. I was happy to see in even the platforms of United States during the last probably transplant programs, transplant web conferences. And Dr. Chetan was very passionate, and I have seen his dedication and the bottom line bedside clinical acumen and managing the transplant in a different ball game altogether. So we will take initial his journey of lung transplant in India, and he's being a clinician from pulmonologist to transplant pulmonologist in the first part. Followed by, we will also request Dr. Charan to bring his journey as a critical care specialist to a transplant critical care specialist. Thank you, Chetan. I do understand you have been going through a couple of transplants and they're weaning from ECMOs and ventilation. And by some reason, I dragged you to this webinar in a short notice. Thank you for being here. So we all, as an intensive care specialist, most of us, to be very honest, are not probably exposed to many. As in the Department of Critical Care Medicine, Yashoda Hospital, we were all fortunate that we could actually witness some of excellent transplant programs happening in Yashoda Group, and in both Secunderabad and Hitec City, we were being a part of those team members. So thank you for accepting our invitation and being here. I request you to share your PPT and carry on. Open to you, Dr. Chetan.
Good evening, everyone, and thanks a lot, Dr. Venkat sir, for the kind introduction. And as sir has introduced, I've been a interventional pulmonologist, and I started my career as an interventional pulmonologist. Then I was exposed to a few cases of transplant, and then I grew some interest in lung transplant, and that is when I went to Vienna for my formal training in lung transplant. And that is where I actually saw what wonders a lung transplant can do. And then my passion for lung transplant just grew from there, and I'm happy to share our experiences with you today, along with what India is currently when it comes to lung transplant programs. So let's start my presentation by thanking this great man. He is Professor James Hardy, who is the first person to do a successful lung transplant way back in 1963 in USA. Unfortunately, the patient died after 18 days, but he died because of kidney injury more than graft failure. But yeah, just because of this, man, here today we are talking about lung transplant. And only after 20 years, in 1983, this great person, Professor Joel Cooper from Toronto, this the first successful lung transplant wherein a patient survived 7 years after transplant. And this could be achieved because of FDA approval of cyclosporine for immune suppression in between 1963 to 1983. So the field of lung transplant since then has made several advances, and currently, probably world over, we are doing somewhere around 4,500 lung transplants in a year. So despite these advances, morbidity, mortality still remain high, and all the programs across the globe are working towards these shortages to improve overall lung transplant survival. And the 36th Adult Lung and Heart Transplant Registry summarized that the survival rates for lung transplant at 1 year is 85%. It is 68% at 3 years and around 55% at 5 years. This was way back in 2018, but the recent case reports or case series that came out in 2023 2024 also reported 90% survival at 1 year, 80% at 3 years, and 60 to 70% 5 year survival rates. So let's also talk about the beginning of lung transplants in India. Dr. P. Venugopal did the first successful heart transplant in India in 1994. Dr. K. M. Cherian did the first heart and lung transplant in 1999. Dr. Yanesh Thakkar did the first successful lung transplant in an Indian patient in 2011. And Dr. Sandeep Attawar did a first lung transplant in a post-COVID patient in 2020. So now, what is a lung transplant for Yashoda hospitals? So we did our first double lung transplant in June 2016. We did our first combined heart and lung transplant of South India in 2017. The first lung transplant for pulmonary alveolar microlithiasis in India was done in 2021 at Yashoda hospitals. Again, the first successful lung transplant in India for paraquat lung was done in Yashoda in 2023. And I am also glad and proud to say that we have done successful lung transplant for the youngest recipient in the world for paraquat lung in 2023, who was a 14-year-old child. And we broke our own record now, wherein we still have the patient in the ICU. And he's the youngest lung transplant recipient for paraquat lung, and he's just 12 years old, hoping and praying for a speedy recovery soon. So as per the registry data, if you can see, majority of the lung transplant programs are concentrated in South India, probably because of more donor programs. And this is again state-wise and institute-wise details of where lung transplants are happening. So Telangana scores the highest when it comes to lung transplants. And present scenario in India, obviously, the organ donor rate in India is less than one per million population, which is very, very less as compared to 20 to 35 per million population in developed countries. This low rate is majorly because of lack of awareness, social taboo, religious beliefs associated with organ transplantation. But despite which, because of support of government organizations and NGOs, lung transplants have significantly picked up from 2017 in India. So this is again from the data from our Noto, which says that there were 197 lung transplants done in India in 2023. So as I said, the total hours allotted to lung transplantation in annual conferences of Indian societies also saw a boost from 2017. So $1 million question, which I want to clear to everyone, irrespective of being a pulmonologist or a critical care specialist, is when to actually consider a lung transplant. So lung transplant should be considered for adults with chronic end-stage disease who meet all of the following criteria. That is, who are at greater than 50% risk of death from lung disease within 2 years if lung transplant is not performed, and have a greater than 80% likelihood of 5 year post transplant survival from a general medical perspective, provided there is adequate graft function and there is no alternative medical or surgical options available. So, this is just a gross point of when to actually consider lung transplant. So, now if you look at the international registry data, the most common indication for lung transplant in 1990s was COPD, But if you look at the data from 2010 to 2018, it is idiopathic pulmonary fibrosis. So pulmonary fibrosis has taken over as the most common indication for lung transplant world over. And this is more so in India because we hardly do any COPD transplants because most of our patients have a lot of reserve before coming to a lung transplant. And when it comes to pediatrics, it has always been cystic fibrosis on the most commonest indication for lung transplant. So let me take you to some simple case scenarios or success stories of ours. Starting with interstitial lung disease, as I said, this is the most common indication of for lung transplant that we have done, and also the world is doing currently. So this is a 39-year-old male who is a stone crusher, had respiratory symptoms for 6 years, was diagnosed as sarcoidosis based on lung biopsy, was on immune suppressive therapy, because of which he had PTB twice in the last 3 years, and there was persisting thick wall cavity which also grew aspergillus, for which he was again on treatment, and he was on a LTOT for last 3 years. And this is a CT. If you can see, there's a huge calcified wall with cavity and multiple calcified nodules in the entire lung. And this was his PFTs, 28% FEC, 27% DLCO, and he is already desaturating even at rest. So there's no doubt he's a candidate for transplant. And this is how we optimized him pre-transplant. If you can see these videos, this is how he was doing his pre-transplant rehab at home. He wanted to save money over dumbbells, so he was very religiously doing it with water bottles because he's from a poor socioeconomic status, despite which he could come for transplant with trust on us. So on the left, if you can see, he was having saturations of 80% on 10 liters of oxygen. So after listing, he got a lung in 5 months, and this is his explanted lung. Probably one of the toughest explants our surgeons have done. The lungs were rock hard. Each lung almost weighed around 2.7 kgs. And this is his post transplant or explant biopsy, which changed the entire diagnosis to silicosis. He was probably misdiagnosed as sarcoidosis, uh, and then he progressed. He got infected because of immune suppression therapy, and now he ended up in a lung transplant. So this is his pre-transplant versus post-transplant X-ray, and he was discharged, walking independently, smiling on 12th day post-transplant, and he just completed 4 months after transplant now. So this is the recent case again. This is a 54-year male with chronic fibrotic HB who was on oxygen from the last 2 years. And this is him who just walked home straight away on 8th day of transplant. So sending a patient on 8th day post-transplant is not very common, at least not even in India, even across the globe. It's very uncommon to send a patient on 8th day post-transplant. Probably this can be achieved because of early referrals. Even the patient is still preserved in the general condition, aggressive pre-transplant physiotherapy and aggressive post-transplant physiotherapy, and multidisciplinary coordinated approach amongst critical care specialists, pulmonologists, dietitians, physiotherapists, nurses, transplant coordinators, and everyone. So cystic fibrosis, as I said, is the most common cause in pediatrics. So this is a case that we have done. This is very cystic lung disease. PFT of showing FAC of 41%, and this is the patient. Even this is on the day of extubation. And this is a non-cystic fibrosis bronchiectasis. So when we come talk about Indian scenario, we do a lot of non-cystic fibrosis bronchiectasis as compared to the Western world. This is a very typical case of post-tubercular bronchiectasis, wherein the entire left lung is destroyed. There's hardly any lung left. So this patient was on LTOT, long-term oxygen therapy, for 3 years. He had a very low BMI of less than 16. We were waiting for him to improve his BMI, but despite maximum efforts, he could not. So we had to take the challenge of low BMI, go ahead with the transplant. This was again a technical challenge for the surgeons because of the adhesions and bleeding, despite which they did a tremendous job, and it was successful. This is on the day of extubation, then post-transplant rehabilitation. And this is the patient 1 year after transplant now. So he's almost completing 1.5 years post-transplant, and he's happy back with his family now. So the new kid on the block, which is common between the critical care physicians and pulmonologists, lung transplants for acute respiratory syndrome. So there was no discussion of lung transplant for acute respiratory syndrome until probably 2016. Only then the international societies recognized it as one of the indications for transplant. So let me again take you through a case. This is a 23-year-old male who consumed approximately 30 ml of paraquat at his residence, was shifted to a local hospital within 30 minutes. Gastric lavage was attempted, then he was referred to a district hospital. He was asymptomatic then, so they just admitted for observation. Then he had AKI after 7 days. Hemodialysis was initiated and continued for 7 sessions. Then patient had worsening shortness of breath, then hypoxia from day 9. Then initially he was started on oxygen with face mask and later NIV support, rapidly worsened, intubated, and then he was referred to us. So when we received him, he was on mechanical ventilator support with an FiO2 of 70% and a PEEP of 6 to maintain a saturation of 90%. PF ratios were 150, AKI was recovering, and acute liver injury. There were grossly deranged LFTs. So this was a CT when he was admitted. So you can see the dependent consolidations with air bronchogram. Then he was usually treated with the regular uh, steroids, antibiotics, supportive therapy. But then he rapidly worsened. PF ratios went to less than 100. So we had discussed with the family and had to initiate ECMO. And this is during his third week of illness. There was hardly any normal lung left out. Everything was white out. So I'm sure everyone agrees with me that there's no coming back from this stage. So we were also in a dilemma because there was never a lung transplant option, or there was never a lung transplant done in India for a paraquat case. So we've been through the literature, we saw some Western literature. We had discussed with the family. The family was like, even if there's 1% chance, let us go ahead. So then we started evaluating him. This was the bronchoscope BAL. It was purely pus. Evaluation was done. There were no absolute contraindications, and he was lucky enough to have a donor on the day of registration itself. We registered him in the afternoon, and he had a donor call in the night, and we did a lung transplant. So this was him on POD2. This was him 3 months after transplant. This is him 1 year after transplant. So now he'll be 2 years in August. And this was him recently who made us all proud by climbing Tirumala hills by foot and also coming down. So this is how normal quality of life a patient can have after a lung transplant. So this is the first youngest recipient for lung transplant in the world that we have done. He was 14 years, now completing 1.5 year. And this is our recent lung transplant recipient for paraquat, who is 39 years, who was on ECMO for 46 days pre-transplant and just walked home 12 days after transplant. This again intensifies how important coordinated critical care plays a role in lung transplant. So $1 million question when it comes to ARDS transplant: is the patient bridged awake or sedated? Bridging patients awake has become an increasingly used practice in lung transplantation, and in some centers, awake patient is even considered a prerequisite. Outcomes are better if the patient is bridged awake. So this is one of our young transplant recipients who came with hypoxic respiratory failure, was in ARDS. Then we had to bridge him, and this is how we made him walk every day. Then he had a successful lung transplant and went home. So, what are the challenges of lung transplant in India? The remedy by eventual organ replacement remains only a dream for vast majority of patients with end-stage lung disease. The reasons being our cadaveric program not taking off and Armenian complex. Like I said, it is because of religious taboos and other beliefs when it comes to organ donation, lack of awareness. And in 2019, the organ donation rate in India was only 0.52 donors per million population compared with 36.7 in the United States. So now, after all this discussion and after all these challenges that we've seen, so the question comes is India ready? So quite a few patients who come to me in a late stage, when I ask them, why didn't you come early? They say that my pulmonologist or my physician told there's no lung transplant in India, or even if it is there, it is not successful. Is it true? No. So I have a 14-year-old here who is successfully cycling around, and he's like 1.5 years post-transplant now. I have a 35-year-old who is 3 years post-transplant and blessed with a baby girl a few months back. I have a 65-year-old female who is happily cooking for her family just 3 months after transplant. And this is our recent 68-year-old recipient who went home 2 weeks after transplant walking. And do I need to say more that yes, India is ready for lung transplantations and we are doing some equal good work as compared to our Western counterparts. Thank you.
Thank you, Chetan, for actually taking us through those wonderful case series. I have seen you those difficult nights also when you have been struggling these cases. I do understand all these success stories came after a lot of efforts and sleepless nights from all the team members and you. So we have now heard from a transplant pulmonologist. The most of our colleagues are also been keen to look for what is the intensive care team members' role and how in the last half a decade, Dr. Sricharan from a regular post-graduation from his MD anesthesiology in exams to a critical care fellow with us in Care Hospital came to Yashoda as a consultant and evolved into a ECMO physician and transplant critical care specialist. He exclusively looks after ECMO. We all look after him whenever we need any guidance. He has been tremendous support to the transplant program. Over to you, Charan, for your brief overview and your journey.
Very thank you for those kind words, sir. So we will be actually discussing about the role of a critical care specialist and what are the actual differences between a regular critical care, what we practice in our ICUs, to what are the extra points or extra mile where we have to go and try to understand these concepts when it really comes to lung transplantation. So when it really comes to lung transplantations, the first thing which quite differs or which is not actually present in any of our critical care medical critical care possibilities is a concept called the primary graft dysfunction. The primary graft dysfunction is happens in both heart transplant as well as in lung transplantation. So in case of heart transplant, it is called a primary graft dysfunction of LV versus primary graft dysfunction of the RV. Whereas in lung transplantation, it is simply called PGD, primary graft dysfunction. So it is a multifactorial injury which occurs within 72 hours after transplantation, most commonly because of reperfusion edema. So when we actually release the clamp of the pulmonary artery and the entire blood perfuses the new lung, an ischemic lung which has been under cold ischemia for so long, we can actually expect some non-cardiogenic pulmonary edema in these patients, which can actually lead to primary graft dysfunction. So the typical histological finding in these cases is diffuse alveolar. So, as the International Society of Heart and Lung Transplantation has actually classified PGD based into PGD 0, 1, 2, 3 based on PF ratios, which is not so different from whatever the classification of ARDS we have as per Berlin's definition. So, the primary graft dysfunctions are typically performed 4 times. That is the reperfusion at the time of the second lung, that's called T0, or sometimes T0 can also be defined as the time within 1 hour after reaching to IC. Then comes T24, 48, and 72, where T72 is considered most important for the prediction of survival. However, the risk factor per se, PGD, is considered as a risk factor for an entirely differently new term where which we learn for the first time when we are doing the transplant critical care is what is known as a chronic lung allograft dysfunction, also called as CLAD. So any organ after a certain amount of time, as days progress by, there is something of a concept called chronic rejection which can occur in these patients. So in lung, it is called a chronic lung allograft dysfunction, which is again divided into two basic types called the bronchiolitis obliterans variant and also called a restrictive allograft variant. So PGD is a risk factor for CLAD, both variants. It has got longer ventilation. It can cause increase in your mechanical ventilation days. It can cause longer intensive care stays. It has higher rates of renal replacement therapy. There is higher rates of reoperation rates. So the treatment simply varies. It is actually a conservative or a sorry ARDS kind of ventilation which can happen in these patients, which should be instituted in these patients. Inhaled nitric oxide is actually going to help, and patients who are having severe primary graft dysfunction, which is not amenable to inhaled nitric oxide or protective lung ventilation, needs to be instituted on ECMO support. However, the recent guidelines say that if the patient is requiring ECMO initiation for the primary graft dysfunction, it should be ideally classified as ungraded EPG. Next comes the perioperative hemorrhage. This perioperative hemorrhage is one of the most common complications previously, but now with the advent of newer techniques, with the better expertise of surgeons, the amount of post-operative hemorrhages and patients who are having hemodynamic instability or significant complications secondary to post-operative hemorrhage is very, very less. However, we have to also understand that patients who are bridged to transplant on extracorporeal membrane oxygenation, they are at a higher risk of actually developing this post-operative hemorrhage, because higher risk of receiving multiple blood transfusions than patients who are not on ECMO. Because of the chronic inflammatory state which they are on because of the ECMO support, and also because of the anticoagulants which they receive during ECMO initiation. So what are the various monitoring which you have to do in our ICU at this time? Is post-operative monitoring is a continuum with intraoperative monitoring. So we typically most of our patients come back with pulmonary arterial catheter, except when the patient is requiring an ECMO support post-operatively, where we initiate a jugular line of the ECMO with the pulmonary arterial access. So because we know that their pulmonary blood flow is oxygenated secondary to a venous ECMO, we will not actually measure their pulmonary artery pressures. So obviously we go for invasive blood pressure monitorings, we go for electrocardiograms, pulse oximetries, transthoracic echocardiography, or transesophageal echocardiography can be done immediately after surgery, or at least on POD 1 or 2, to actually understand state of how is the myocardial function or the right ventricular function. The one caveat here is that because that being a surgical field, sometimes there might be some degree of trapped amount of air in your subcutaneous spaces, which can make transthoracic echocardiographic windows quite difficult to achieve. So in these patients, transesophageal echocardiography is done. So we have to also understand that even though these devices are actually giving us a lot of information about the patients, there is always a chance of infection, which can happen with significantly high frequency in patients who are post-transplant, owing to their immunosuppression status. So as I was telling you, mechanical ventilatory strategies are not so indifferent from what we use in patients with ARDS. However, when I'm actually telling you that in these patients, we have to go for 6 ml per kg body weight per kg of ideal body weight. We also have to understand that this ideal body weight should be calculated based on donor height, not on the recipient height. So this is one important thing which we differ in approach when it really comes to mechanical ventilation strategies in patients who are of lung transplantation. So the PEEP level should be ideally be applied, adequate amount of PEEP, low tidal volume ventilation, and all the caveats of what we use in ARDS ventilation is valid in patients who are post lung transplant and in whom we have suspecting PGD or even in the treatment of PGD. So fluid management, this is something which is of a case to case based thing which we generally use in our ICUs. It is ideal to use as much restrictive strategy as possible as the urine output and the cardiac output is being measured. So in our ICU, we typically use a continuous cardiac output monitor and base our fluid management based on the cardiac output and also on our stroke volume variations which we see. So based on that, we also measure the other parameters of adequate cardiac output, including the urine output, like the downtrending of the lactates post surgery, and these are actually considered as adequate fluid resuscitation. So we typically use a continuous cardiac output monitoring in this case. Now, the one thing which any solid organ transplant patient receives is an immunosuppression, and this immunosuppression are broadly classified as induction immunosuppressions as well as maintenance immunosuppressions. Induction immunosuppressions are controversial, and the most commonly used basiliximab as an induction immunosuppression in most of our patients. However, Western literature says that they use alemtuzumab, which is a more profound immunosuppression. There are also reports where people use antithymocyte globulin as an induction immunosuppression in lung transplant. We have used basiliximab classically. And maintenance immunosuppression includes 3-drug regimen, which includes a calcineurin inhibitor, a corticosteroid, and a nucleotide blocking agent. All of our patients, most of them have received mycophenolate mofetil or mycophenolic acid, mycophenolic acid. And these patients receive 1 gram of mycophenolate mofetil or 720 milligrams of mycophenolate sodium intraoperatively. And we typically start our calcineurin inhibitor on day 2 to day 3 based on the urine output and their renal parameters. So The corticosteroids, we typically give around 500 milligrams to 1 gram of corticosteroids intraoperatively, where they give 500 milligrams as a bolus and 250 with each lung reperfusion. And based on whether or not they have received induction immunosuppression, there are various times where we give around 1 milligram per kg body weight of corticosteroid in the post-operative period. So, as opposed to other transplants like kidney transplant and liver transplant, lung transplantation and heart transplantation require higher maintenance immunosuppression because these tissues are typically having higher immunogenicity. So, therapeutic drug monitoring is important for individualization of tacrolimus doses, and typically we maintain around 10 to 15 nanograms per ml of tacrolimus, trough tacrolimus actually. Antimicrobial prophylaxis, even though the international community tells us that there is a broad range of antimicrobial prophylaxis where they will ideally need to give a third generation cephalosporin, cefepime with along with vancomycin or teicoplanin for gram-positive coverage, which needs to be continued for at least 5 days. Given if we actually typically look for the MRSA colonization pre-operatively, and because the MRSA incidence in our hospital is significantly less, we generally don't go preemptively for a MRSA coverage, namely with the vancomycin and teicoplanin. Most of our patients, if at all they are clean enough, or not who are not actually fixed to transplant with an ECMO support, they receive piperacillin tazobactam as an intraoperative antibiotic prophylaxis, which we continue typically for 5 to 7 days and stop. So coming to CMV prophylaxis, almost all our patients receive CMV prophylaxis. So 99%, among all the patients which you have seen, only one patient was received R minus status. Everybody else is R plus status. So majority of them are D plus R plus status at this point. So we will be giving valganciclovir prophylaxis. Initially, we start with intravenous ganciclovir, and then we change to valganciclovir prophylaxis. And at the same time, during the 2-week course in the ICU, at the end of the third day, we typically look for any reactivation of CMV by looking for quantitative CMV DNA PCRs. All patients receive pneumocystis prophylaxis, and also they receive majority of them receive fungal prophylaxis. So most of the thing is the chances of post-operative fungal infections, at least after discharge, is also more given the environmental exposure kind of thing. So most of these patients will receive fungal prophylaxis in our institute. So the majority of cases they receive voriconazole as a primary mode of fungal prophylaxis, which is given at a dose of 4 mg per kg every 12 times. And if the patients are actually having intolerance to voriconazole secondary to any transaminases or liver-related injuries, we go for alternative therapies. Most of the common alternative therapies which we use are posaconazole and isobuconazole. So even they are actually associated with some degree of liver-related injuries, but they are safer than voriconazole when it really comes to liver injuries. Coming to physiotherapy, so this is one of the important things where we want to concentrate in the post-operative period of lung transplantation, because this is one thing which can actually turn the tides for a patient. So a patient who has been walking, the best patient who can actually undergo a lung transplant is a single organ dysfunction patient who is practically walking to you in your OPD. So a patient who is not so if a patient who is not walking or completely bedbound with very less muscle power has got very high risk of mortality. Even in International Society of Heart and Lung Transplantation says that the patient whose chances of adequate physiotherapy post-operatively are very less are considered almost a relative contraindication for lung transplantation. So post-operative physiotherapy is one thing which can actually make a difference in the patient's recovery after lung transplantation. So if at all these post-operative, so we will be pursuing physiotherapy in the immediate post-operative period as early as POD1 or POD2, where you can actually see that this patient is still connected to ventilator. We were able to get her out of bed on ventilator with a control mode of mechanical ventilation going on. She was actually able to do a lot of physiotherapy. So we will be pursuing this physiotherapy to very aggressively in the post-operative period. So this is our patient who is a 30-year-old, 29-year-old female who actually underwent a heart transplantation for peripartum cardiomyopathy. So she has been significantly sick for the past 4 months, and then she actually underwent a heart transplantation. You can see here that she's actually extubated on POD1, and on the day of extubation itself, we were making her sit on a chair. So these kind of patients or these kind of response from a patient is what actually drives them home quite early. So as I was actually discussing about the post-operative aspects of a lung transplantation, and in the intensive care unit, one thing what we have to also understand is that there are good number of population of patients who might undergo ECMO as a bridge to lung transplant. If most of these patients, almost 100% in our case, actually are veno-venous ECMO who are bridge to lung transplantation. And as Dr. Chetan was actually telling previously, any patients who are, even though are in ECMO, are to be awake to be actually considered for lung transplantation, because patients who cannot be brought awake are considered very poor candidates for lung transplantations. So, awake ECMO is one thing which actually facilitates physiotherapy and rehabilitation. It decreases ICU delirium and decreases the incidence of post ICU syndrome. And the American Association of Thoracic Surgeons actually have given a guideline on the utilization of extracorporeal support therapies for before lung transplantation or during lung transplantation. They are given that femoral cannulations, even if it is a BV or a BA cannulation per se, cannot be considered as an absolute contraindication for mobilizations. And these patients who are initiated on ECMO for as a bridge to lung transplant should be aggressively pursued for adequate physiotherapy. So this is what I was actually telling you about. So the femoral cannulation should not be considered a contraindication to ambulation and rehabilitation in patients supported with veno-venous ECMO as a bridge to lung transplant. So how there are certain population of patients whom based on their readiness, we will assess their readiness, and actually we will extubate the patients on ECMO so as to stimulate their respiratory muscles and diaphragm of the lung transplant, so that post lung transplant their with strong respiratory muscles and a good diaphragmatic function, the chances of them staying or coming out of ventilator quickly is quite possible. So we can actually see it is these kind of approaches what we do pre-transplant, where with adequate breathing exercises, strengthening their respiratory muscles, strengthening their diaphragm and overall exertional capacity, which makes us possible to discharge a patient on day 8 or day 9 as we have seen previously. So when do we consider extubation on ECMO is that we have to assess the readiness where there is absence of multi-organ dysfunction. The patient should be awake and cooperative enough. The patient should be having adequate cough reflex, or if the patient is having poor cough reflex, but considering regular bronchoscopies cannot be practical. And PEEP dependent individuals should not be included. So the patient should be able to maintain reasonable amount of ventilatory drive. So it is not that the patient is having hypoxia or hypercarbia, but their ventilatory drive should be manageable. If the patient is breathing at 45 consistently, even though his saturations are 91, 92, then I don't really think that is actually a good patient enough to extubate on ventilator. So we always explain to the family saying that this patient might at any time require mechanical ventilation again, and most of the times we will not give extubation trial more than once. Most of the times, if the patient gets reintubated, we will go for a tracheostomy and we will bridge to transplant on a tracheostomy, and then we will try to make them breathe on their own with a tracheostomy tube instead of an extubator. So, but the ability to clear their own secretions, the ability for it also helps in their psychological well-being if the patient is extubated and where they are eating foods now. So this was what Dr. Chetan was actually showing. He was a scleroderma ILD on long-term oxygen therapy with severe type 1 respiratory failure. So after failed HFNC and NIV trials, he was subsequently intubated. Obviously, intubation did not actually help him much, and the patient was after intubation, he was subsequently instituted on an ECMO support. And after he was instituted on an ECMO support with the mechanical ventilator, so we were able to bring him down onto pressure support and subsequently extubate him. And then we were able to make him walk in the ICU. So this is he subsequently came out of the transplant, and then he was actually breathing normally on room air. So this is actually a patient after the lung transplant. So secondary is a 40-year-old female with complaints of progressive shortness of breath or myalgia. So you can actually see that these patients will receive minimal or no sedations during ECMO support. So as long as they are calm, we will rather let them be. This patient did not actually tolerate a spontaneous breathing trial properly, so we were not able to extubate this patient, but we performed a tracheostomy, and then we tried to keep her awake and try to improve her overall muscle status and weakness by physiotherapy. So this is actually a 64-year-old female with ILD, presented with severe type 1 respiratory failure. So she was similarly subsequently intubated after NIV and HFNC failure. So to facilitate physiotherapy and rehabilitation, we initiated her on ECMO, and then we subsequently extubated her. So age might not be considered as a criteria as long as the patient is tolerating adequate physiotherapy. even though this patient, all the patients which I've shown you are on femoral as well as jugular access for a venovenous ECMO. So femoral access and jugular access cannot be considered as contraindications, and we obviously we have to take adequate care in order to secure these cannulas such that there is no dislodgement of these cannulas. So she was subsequently extubated on ECMO and underwent good rehabilitation. So after ECMO, she was instituted on, she underwent a lung transplant. And after undergoing a lung transplant, we were able to decannulate the ECMO on POD0 itself. So, and then she was subsequently extubated. And then you can see actually with minimal amount of oxygen, she's able to perform her activities, which she has actually insisted in this scenario that she really wants to brush her teeth. So how far can we take? So the patients with 29-year-old female with LSCS, post LSCS, she presented with one severe ARDS. So we have actually tried everything under the roof for the resolution of her ARDS. In view of very poor PF ratios of 75, she was subsequently instituted on ECMO support, and because of the posterior dense consolidations, we proned her on ECMO support. In spite of which, when the patient did not actually undergo, when the patient did not improve, subsequently she was bridged to lung transplant. You can actually see that the decision for bridging takes place typically around after 4 weeks of adequate ECMO therapy and then on maximal medical therapies. So whenever, in spite of she being on 4 weeks on ECMO support, you can actually see that there is some degree of muscle power which is preserved, which is not as strong as the other people whom I have actually shown you in the previous slides. But you can see that the muscle power is somewhat preserved as opposed to a patient who is typically sedated and paralyzed for weeks together. So this is a patient with rapidly progressive ILD. So why am I actually showing this picture is that we have used dual lumen cannula in these patients. So this dual lumen cannula can also be used if in patients which can facilitate much better physiotherapy and rehabilitation. However, one thing which you have to understand for the dual lumen cannulations are that they don't give as much flows as a single lumen dual two-side single lumen cannulations can give. So supposedly their RPM can be a little better, or we have to go for a significantly larger dual lumen cannulas, and there are financial implications being dual lumen cannulas being significantly pricey than the single lumen cannulas. So this is actually a patient with severe interstitial lung disease who was bridged for lung transplant. The specialty of this patient was that he was also having a significantly large neck. So we were almost pretty sure that we will not be able to ventilate this patient with an ILD lung and with the ongoing hypoxemia. So we have actually instituted ECMO in this patient while he was awake. So we sedated him with dexmedetomidine, and under local anesthesia we just gave a local anesthesia to the thigh as well as to the neck, and then we initiated ECMO in this patient. So he was never intubated before lung transplantation. So the reason of this everything is that ECMO should not be considered as a hurdle for adequate physiotherapy and rehabilitation, which should happen before a transplant has to happen. So we can actually say that we have done a significant amount of physiotherapy, even in physiotherapy sessions happen even in our medical ICUs and neurocritical care units also. But one thing what we have to remember is for patients who are undergoing lung transplantations, probably like the amount of physiotherapy that should happen inside the ICU is way too high. So we will be actually having a very specific rounds with the physiotherapist to actually understand where are they and how are they progressing. So bridge to transplant patients are more preferably extubated if at all they tolerate. So we have to keep very strict stringent criteria and checklists for extubation and ambulation, and they should be maintained as this. So obviously staff training is important, and finally all the cannula should be reinforced. So the cannula site should be reinforced so as to prevent any catastrophes of accidental cannulation dislodgements. Thank you.
Thank you, Sricharan, in bringing those important areas of which makes critical care, transplant critical care special and different from the regular ones. With this, I will try to bring some interesting questions to both of you. First to Dr. Chetan, very precisely, what are the challenges currently you're facing? Is it with the patient? Is it with the primary clinicians? That means I'm saying the appropriate referral is the issue, or the families are not ready, or the patients are not ready to come to you.
I can say it is two ways, sir. So it actually starts, the main problem actually starts with the late referrals, as I said. So if you look at our center's experience, at least 65 to 70% of transplant that we did in this year are all bridge to transplant on ECMOs. So that itself indicates that most of our cases are already referred late when they are intubated somewhere else and shifted here for ECMO, are already initiated on ECMO and shifted here. So it's very well proven that such late presentations or bridge to transplant ECMOs have certainly slightly lower results as compared to other transplants. So I think it is pertinent to create awareness at the physician level or the treating pulmonologist level to refer patients early. Like I said, one of the patients that we recently discharged just walked away home on eighth day without any challenges. He was just on minimal antimicrobial
So
support,
you mean
nothing
to
to be
say
done.
a patient with at least only single organ and preserved musculoskeletal system and preserved other systems has a higher chance than the patient who's already on bedridden with a ECMO support bridging for a transplant. So, but the
Very true.
problem will happen is families and the primary clinicians will be always skeptical about when they are actually planning for a transplant which goes with a high risk. So this kind of apprehensions will actually push them towards the wall till the last point. So what will be the critical point where you think patients should be considered and evaluated for a transplant? What is that critical um, point which you break point which you think?
Sir, I like you rightly said, it's all about apprehension, and it is also about to do a lot of with cost implications when it comes to developing countries like India. So as we look at the ISHLT guidelines in the Western world, even desaturation on exertion is considered an indication for transplant. But I am sure we will not be able to push any patient of this category to transplant. So at least once they are on minimal oxygen support and once it starts gradually worsening, that is what is the point where they have to be forced or told about lung transplant, and it has to be told by the primary treating physician that this is the only option now, and that is where they actually tend to understand. So
You
someone
may
who is stable on minimal oxygen and suddenly worsens, that is what is the point.
So you mean to say the end stage lung disease, irreversible end stage lung disease needing oxygen therapy and worsening of ongoing progression with incremental oxygen requirement and limiting his regular life,
Physical activity.
probably physical activity or a regular activity is the time where they should be visiting a transplant clinician or a transplant pulmonologist along with the primary clinicians involvement is the ideal time to say. But the
Yes.
other component which always is there, one point you said is finances. Yes, that's always been a task in Indian context. There were some questions related to that also. I hope that will be a very difficult question, and it may vary from center to center. But grossly, what is that which we generally look at?
You mean the cost?
Yes.
Yeah, so most of the programs like in India are somewhere around 30 to 35 lakhs for the lung transplant per se. But when it comes to cost about a lung transplant, we have to be very clear to them about the post-transplant implications also. It is not just like a one-time investment that you do an appendicectomy and go home. So we have to be very clear to them about the cost of immune suppression therapy that is to be taken lifelong, the follow-ups, the surveillance bronchoscopies, the biopsies, and so on. So we are very clear to our patients about the cost of transplant per se, and also we clearly explain them about what it takes for a post-transplant care, and that is how we prepare them for a transplant.
We're talking about somewhere average thing. So keeping cost aside, what are the other challenges? There will be many challenges related to the availability of the organ and waiting period. So, what is that where we stand right now?
So I think currently in India we are not at a stage where we still have a very high waiting list mortality. And for that matter, most of our deceased donors' lungs are not even utilized. Even if the quality is good, the rate of our utilization of lungs is only 20% approximately in India. So our waiting list or waiting time is somewhere between 2 weeks to 6 months. So we still have sufficient donors. Probably we are lacking on the recipient side in India, is what I feel.
So that is because of awareness, because
Lack
of
of awareness, late referrals,
late
and
referral,
financial
cost
constraints again.
cost is maybe a concern and a challenge. So I hope you may come back with many permutation combinations to help those who are underprivileged and still wanted a transplant. Many I could see happening in and around you. Coming to Charan, how difficult it is to be a transplant critical care specialist handling clinicians like Chetan and similar kind of clinicians in and around, and even transplant surgeons.
It's actually as Dr. Chetan was telling previously, sir. So it's always a teamwork. So the chief surgeon repeatedly tells me, but whatever we are actually managing in an ICU is the continuum of whatever that has actually happened in the outpatient theater. So smooth surgery, smooth intensive care stay. So a patient whose surgery went like seamlessly, spotless, and then patient comes to the ICU and not on ECMO with reasonably minimal mechanical ventilator settings, minimal or no primary graft dysfunction, and then probably by day 2 we will be able to extubate the patient. And then after extubation, physiotherapy, and I think just things go in like clockwork. But severe primary graft dysfunctions like bleeding or any bleeding related complications, patients who are especially being bridged to transplant on ECMO and who have been there on ECMO, as Dr. Chetan was giving an example where we had an ECMO patient who was bridged for 47 days. So we can only imagine the muscle power and their muscle strength in the during the preoperative phase, and as well as that actually. Translates into significantly long mechanical ventilation stays, longer LOS in the ICU and all. So one thing which I found very different from when I was actually working in medical ICU versus at transplant is I'm more obsessed about physiotherapy for the patient. So
I,
patients.
I'll probably come to that. I could actually see that in your presentation. But what you said is we have seen a different spectrum or a wide spectrum. Few of our cases who actually got discharged in 7 days time, 8 days time, which Dr. Chetan was talking about. We were just bystanders. We hardly had anything to offer. We just extubated, decannulated, just made the physiotherapy done, and the patient was walked out. And it is like any other renal or a liver transplant or like any other post-operative case where we felt it is so easy. But we have seen another spectrum of cases who gone through all possible complications mentioned in the transplant immunology or a transplant pulmonology, from hyperammonemia to encephalopathy, ICU delirium, to everything, infections and all that stuff. So we see that spectrum, and I agree with you that the second point which you raised is the physiotherapy, awake ECMOs, keeping them having their muscle power intact. I think all the transplant team, either surgeon, pulmonologist, and intensivist, has been very, very focused on that. I could see that happening with Dr. Chetan today when he wanted one of our patients who have been post-paraquat onto a bridging ECMO for waiting for a transplant. He wanted the relaxant to be dropped, and the relaxants were just added because he was desaturating to 40s, not having a sync with the ECMO, and there was some concern. So he wanted them to drop, and we were trying to plan. It's a easy. We all want the patient to be on awake and stable ECMO. That is quite possible when it is a patient who came electively for a transplant and because he was hypoxic and bridged. But what about a patient, somebody who had a ARDS or a paraquat, needing a kind of a sedation, relaxant on and off? How do you manage them? So what is your trick? How do you make them awake? How do you actually crack those irritabilities, crack those dyssynchrony and all?
So there are certain population of patients, especially the first initial one or two paraquat lung poisonings, where we were actually seeing the CT scan with complete whiteout lung with only air bronchogram that was visible at that point. So that patient was practically not possible for us to get him awake before the transplant because his entire cardiac output has to be practically oxygenated with the ECMO for him to maintain saturation. So it demanded that we have to sedate and paralyze. So we were quite skeptical about his muscle recovery in the post-operative period, but he has shown good recovery. But most of the times, patients who are having some degree of residual lung functions, we will try to put them on pressure support ventilation or pressure control and assess their readiness. So we'll start the weaning from mechanical ventilation strategies are not so different when we are doing it on ECMO. We will use the same thing, but not the oxygenation as well as the decarboxylation targets. The ideal thing is for a patient who is being bridged to recovery, I would even tolerate 83 to 85% of saturations unless and until it is translating into hyperlactemia or actual hypoxemia. But whereas 83 to 80 to 85% saturations in a patient who has to be awake will again stimulate his respiratory drive. So my oxygenation and oxygenation targets are higher. I will put higher than normal sleep gas to maintain the PCO2 levels between 30 to 35 so that their drive doesn't get stimulated as much as it should. And then we will try to slowly wean off sedation, and we typically come down on the opioid related sedation and come down and increase our dexmedetomidine and also add some antipsychotics and anxiolytics so to make them as calm as possible. So with that, we will be able to come down to reasonable extent of sedation
It's a
where we
cocktail of dexmedetomidine, antipsychotics, anxiolytics. That's what you
will
meant.
anxiolytic. Yes.
So dexmedetomidine is one. Antipsychotics, do you use risperidone, quetiapine, or a
Quetiapine, sir. Quetiapine we use, and
combination?
anxiolytics we use clonazepam.
Clonazepam in a
Clonazepam.
combination of that. Do you use any pain relief analgesics in them?
Fentanyl, sir. We'll be giving 25 mics of fentanyl as an infusion. We will be giving. Or most of them, if they are hemodynamically stable, we use a transdermal patch, fentanyl transdermal patch. So I have a patient right now who is 60-year-old who was extubated on ECMO. So he's on HFNC support just to decrease his work of breathing because he has had severe usual interstitial pneumonia pattern. And then he's on this cocktail of dexmedetomidine, quetiapine, clonazepam, and a fentanyl patch of 25 mics per hour. So to keep them
I
as
also had a similar kind of experience with Chetan and his one of his patients where Dr. Misra transported from uh, Goda to our unit. Same, the power was almost very difficult to actually sedate and paralyze, and we were expecting him to go through a lot of turmoil. But these young individuals with other things very normal, post-transplant, this patient was miraculously recovered like anything. Chetan, we were all anticipating his recovery will be
Yes.
very turbulent because his power was very difficult. Somehow, these paraquat patients, one they get a fresh lung and they start getting oxygenation. I'm not sure they get this power from somewhere, and their recovery trajectory is much better than other chronic condition which we have seen. Any comments, Chetan, on that?
Sir, probably this is because of lack of immune suppression in these patients who are otherwise normal. All the paraquat patients are all otherwise normal except for paraquat-induced injury. On the other side, where you see your ILD patients who are always on ECMO were on steroids since quite some time. So there is some existing steroid-induced myopathy and all. They're gradually deconditioned because of oxygen dependency, lack of rehabilitation potential, and all. So that pre-transplant lack of rehabilitation and decondition translates into bad results post-transplant. On the other side, these paraquat patients are otherwise well preserved. They had no other issues before this incident. So their general condition is very much preserved. There's no second organ involvement, and they recover fast after a transplant. It's just that we have to tide over the crisis of infections, bleeding risk, and all that, and they do very well. Like we've seen that 47 days of ECMO. He was having all XDR, MDR bugs, you name it, and he's been through profound shock. He came out of it, then he underwent a transplant, then just walked home on 12th day as nothing happened before.
Yes. We wanted this all discussion to be saved for the next webinar on paraquat transplant, but there are questions related to that. I think we will be very precise and answer them. But yes, we were all proud to see that few of our patients who underwent transplant in paraquat poisoning were first of its kind in the world, and they were all waiting for the international publications, including Chetan's few cases now. But the question is, what is the window period after which you will consider a paraquat patient to be undergone a transplant?
Yeah, so as per the previous literature, I think it is 4 weeks is the cutoff, sir, because the initial lung transplants that were done within the 4 week interval, they didn't make it, and the postmortem analysis of those lungs also showed paraquat induced injury in the graft. So that is where they come to a conclusion that you have to wait at least 4 weeks from the ingestion. Your kidney and liver has to come back to normal. There is no second organ injury. There is no active blood sepsis, and then you can go for a transplant.
Other than urine diathylamide test, any other test you do for paraquat in the lung or in the blood?
I guess in the Western world they do some muscle biopsies to see the paraquat concentration, sir, but I'm really not very aware of it, and we do not
None
have
of
it
your
in India.
patient has gone through any such test.
No. We just
And
did that urine screening.
currently, all these 3 paraquat patients still don't had any lung injury, at least with paraquat.
No, sir. No.
Okay. Coming back to you, Charan, you have been actually running ECMO training programs. I think a few of our fellows across India are also being fellows in your unit. So do you think transplant critical care being a specialty in the future? How do you see that as?
Definitely, sir. So, as we were actually looking at the statistics, where the number of transplants in India are actually growing in the last decade, and people are getting more aware of the transplantations, and so we actually see, and there are certain aspects of in transplant critical care which are quite special to it. In sense, it's quite dedicated, like quite unique to transplant critical care. So. So I would definitely see as transplant critical care as growing as a separate specialty in the near future, probably in the next 3 to 5 years itself.
Thank you. Thank you, both of you, for this wonderful discussion. And I hope we will bring a proper exclusive program on paraquat transplant program, which has actually done by Yashoda Group as a leaders in that field. And probably those all happened accidentally, but those all patients got benefited out of it with a lot of, I think that created a lot of interest for many other cases like that. So thank you, Chetan, for being with us in spite of a very busy day today for you and hectic day. Best wishes for all your patients coming out.
Thank
Thank
you
you,
so much, sir.
Charan, in coming in such a short notice, and best wishes for your future ECMO programs and transplant critical care programs. I hope as a society, as a critical care department, we will bring forward that proposal of creating a extra specialty for you. Thank you all.
Thank you, sir. Thank you so much.
I conclude the session.